have, there's a different way of doing Nearpod where it's not multiple choice. We're going to have blanks where you just type in the answers. It's the same format, we'll just do it on an online version. Yes.
And you said it's not multiple choice?
The image review is not multiple choice. It's going to be just like you are used to doing it last semester where you write the answers in. The only difference is we'll be typing them in.
Oh, so we're going to get like an answer. What is it? What is it? Like answer choice? Like answer choice and just fill in the blank? Gotcha.
I'm going to pretend I didn't hear that. But, no, there will not be an answer key. No, not for the image review. That has to be done by memory. And that is practice because we're going to be doing lots of image reviews on your comps, guys. That's practice for that as well as your registry. There's a reason for that. Because there will not be an answer key for the images.
What about spelling?
As usual, as long as you get close to the word, I'm not gonna be too harsh on that. But if you're way off, then yeah, we wouldn't count that. So if you write DIP instead of PIP, that would be incorrect, obviously. So you gotta be accurate, but spelling's not gonna be a huge deal. Don't think too hard on the spelling. So guys, so with this little activity we did, while it was cute and fun, there is a big reason for that. If you've ever studied the different learning styles that people have, you have what's called visual learners. You have
Mute yourself, Mr. Gunny.
You mute yourself. We can't hear you.
Sorry. I don't know why it just... Okay, there we go. Okay. What I was saying was, the reason we did this activity was not just for fun games, for cuteness, competition, while it's all nice and fun and cool, there actually is a good reason for it. There are multiple types of learning styles. There's 3 major learning styles, but there's little subcategories within that. But you have what's called visual learners, auditory learners, and kinesthetic learners. A visual learner learns primarily by visualizing data, pictures, information. They almost have kind of like a photographic memory kind of thing going on where they recall images. That's my learning style, by the way. I'm very visual. Auditory learners, where you learn by hearing information and you kind of record it in your mind. Then you have the kinesthetic learners, which can be some of the most challenging type of learner. Kinesthetic learners are those who learn by having the hands-on, touching things, manipulating things. So obviously, this was kind of a combination of visual and kinesthetic with the Play-Doh models and the drawings. Now, one thing I recommend to you guys personally, moving forward studying this anatomy, is to challenge yourself by, I would keep your model you have right now, by the way, keep it and label it, because that's a great source to help you study. But challenge yourself, buy some Play-Doh or do your drawings, do it from memory, see how far you get without looking at the anatomy, and you would not believe when you get to the test next week how you're going to be able to recall that information. It's a very incredible and very useful way to study. So I do challenge you guys personally to go out there, buy some Play-Doh if you haven't already, or just do your drawings, whatever's most effective for you. Do it all from memory like we just did. See how far you get, then check your answers and see where you need to focus your studies on. Just an extra way you can study the anatomy because there is a lot of anatomy coming at you, and that's going to help you recall this information a lot better, I promise you. So, with that being said, we will do this again. So if you have not purchased Play-Doh, try to have that for the future so everyone can do the models at the same time. And we'll think of other ways to keep the competition fierce as well. But those that do win will get a bonus 2 points on their exam. That's going to be the reward moving forward for each of these that we do this semester. So I hope y'all enjoyed that. I will let you know the winner once I look at all your pictures later today. And let's go ahead and jump back into lecture. We're going to start getting into the positioning aspects of the upper extremities. Let me go ahead and pull this up. Okay, so we are going to start at the fingers and the thumb. Fingers and the thumb, our digits specifically. All the different little positions that we do for those. Let me get your faces pulled up here so you can see. There we go. Okay, we're going to start with a simple PA finger. PA finger. Now, by the way, in radiology specifically, when we talk about doing x-rays of the fingers, we're talking about digits 2 through 5. The thumb gets its own category. So when you see PA finger, that is only referring to digits 2 through 5. Pointer finger to pinky. Pointer finger to pinky. One more time, thumb gets its own subcategory in x-ray. Now, for the central ray on a PA finger, the central ray will always be to the PIP. If you remember, that stands for the proximal interphalangeal joints. The easiest way to remember that, when you're doing an x-ray, guys, on fingers 2 through 5, you're always going to put the central ray basically at the patient's knuckle. You put that central ray on the knuckle. I'm sorry, not the knuckle, the middle of the finger. I'm jumping ahead. Middle of the finger, right here, middle of each finger. Where the finger bends at that PIP. Put your central ray on each of those little indentations. That's perfect centering every single time. Every single time. Hand is flat on the surface. Completely flat. If you remember from lab, if you rotate your hand up, it's going to turn into an oblique. So you want to make sure that hand is completely flat on that CRA. It's very vital to get a correct x-ray. Some patients will fight against that, especially if their finger is broken. But you do need to make sure that that finger is nice and firmly against that IR. Some people will try to hold it above the IR. Guys, remember, if we have that finger or whatever body part it is above that IR, it's going to create what we call OID. OID would be a magnification of the body parts. So we do need that finger to be flat against that IR, as flat as possible. And I'm sure you guys have already learned this in lab. You do want to make sure, let me get my little laser pointer here. When you're placing your anatomy on the IR, guys, depending on what finger we're looking at, make sure that's central to your IR. In other words, you wouldn't want to put the finger over here in the corner. See where I'm pointing to? You wouldn't want your finger over on this corner. You want whatever finger we're looking at to be central to that IR on all sides. And a big reason for that is because we're dealing with much smaller anatomy, if we're not central on our cassettes, the quality suffers quite a bit. It becomes muted or washed out. And these are very small body parts. We need to see high levels of detail, especially if it's just a hairline fracture on the finger. We're not going to see that if we're not central to our film. So as centered on that film as possible, we're at 40-inch SID, of course. We're going to be at 40-inch SID for everything that we're doing in this whole semester. And collimation is going to be very important, once again, because we're dealing with smaller body parts. I don't need the whole hand on the x-ray. If I'm looking at a finger, collimate just to that finger. And that's going to increase the quality as well. We do want to once again see the high detail on these fingers in case there is a very tiny fracture that could be missed if we didn't bring that collimation down and make sure that finger is central to that cassette. CR to the PIP of each finger, whichever one it is. Now, when we talk about the routine exams for fingers, the routine exams will always include a PA, an oblique, and a lateral. It's always going to be a 3-view x-ray. You do see the little initials AP here in parentheses. That's an alternative. If that patient could not put their hand flat on the IR, they have the option of turning the hand the other way. It's more comfortable. That's not what we would call an ideal x-ray. That's just a backup plan just in case they can't put that hand nice and PA for you. PA, oblique, and lateral. Make sure you pay attention, guys, when you get your orders. Make sure you know what finger you're actually x-raying. If they have the third digit listed, which it'll say the third digit, make sure you're x-raying the third digit, not the second or fourth. It's a big deal. We don't want to x-ray the wrong parts. Also, when you talk to your patients, I will say this from experience, doctors order the wrong fingers all the time. You got a lot of fingers to choose from. Ask your patient and make sure that they have pain in the corresponding finger. So if the order says the second digit x-ray, make sure you ask, do you have pain in your second finger? If they say, no, actually the pain's in my pinky, we got a big problem there. Don't x-ray that second finger. Call the doctor, make sure they ordered that correctly, make sure we're x-raying the correct parts. That's probably one of the most common piece of anatomy that people x-ray wrong because the doctors order them wrong. They get the fingers mixed up. Now, as far as evaluation criteria, we, of course, want the entire finger to be demonstrated on that x-ray. And when I say entire finger, that is the distal phalanx all the way down to the base of the metacarpal. distal phalanx all the way down to the base of the metacarpal, which we can see on this x-ray right here. We don't want to cut those metacarpals off because that is considered a part of that entire finger, that entire digit. We do want the central ray to be at the PIP joint, proximal interphalangeal joint. And no rotation, very important. And you need to make sure you're paying attention on those films. Patients, they love to relax their hand, and sometimes when they relax their hand, put that digit into an oblique position. Make sure it's nice and flat in that true PA. Exposure factors, you're going to use very small exposure factors because you're looking at a very small body part, and no motion is going to be key. People will move their fingers, and if there's just a slight bit of motion, that x-ray is going to become blurry. And as I've already said, we want that to be a high detail x-ray to the very small body parts. And watch your marker placement, guys. Because you are collimating so tightly, make sure your marker is within that light field. It's very easy to cut that off. So you want to just put it real close to the finger, and you'll see part of the marker is cut off. That is okay. As long as you can see the majority of your marker, you're in good shape. Don't feel like you have to get that entire marker on there, though, especially when you're collimating really small to those small body parts. We can see nicely demonstrated there's our fourth metacarpal, there's our fourth MCP joint, there's our proximal phalanx with base, body, and head, there's our proximal interphalangeal joint, and our distal interphalangeal joint, as well as the distal phalanx and the middle phalanx. Now, one other thing to keep in mind with fingers, depending on what facility you go to, where I used to work, they always wanted 2 fingers included on an x-ray. That's how I still personally do it. And the reason for that is, this is not your book, by the way, it's just the way Mr. Donahue does it. I always include 2 fingers on my x-rays. So if I was doing the 4th digit, like we see right here, I would include the 5th digit or the pinky on my x-ray as well. And the reason for that is doctors will often look at 2 fingers to make comparison views, to make sure all the anatomy is lining up correctly, to make a comparison in case something looks like a fracture. It's just a little something you can do to aid the radiologist, but if your facility you're at only requires 1 finger, stick with the 1-finger method. But I personally always will x-ray 2 digits, just because that's the way the doctors required it where I worked at. Not in your book, just something I'm telling you about in case you ever encounter that. Has anyone done a finger x-ray yet in the clinic? John has? How'd it go?
Pretty good. I mean, really, it's not that difficult of an x-ray, I don't think.
So was there a fracture, or what were they getting the x-ray for?
I don't think we saw a fracture. She just said she had pain in her. We actually didn't do finger. We did hand.
Okay. And then, yeah, finger. Yeah, okay. All right, so that second view, guys, is going to be the PA oblique finger. Once again, that is digits 2 through 5. 2 through 5. PA oblique finger, that's going to be a 45-degree oblique. We're going to have that digit parallel to our IR. And the CR does not change. The central ray will still be at the proximal interphalangeal joint of the finger you are x-ray. Proximal interphalangeal joint of the finger you are x-ray. Now, some of the facilities you can go to will have what you see right here in these pictures, these nice little finger sponges or hand sponges. If they have these, I really highly recommend using them because it's going to put the hand in a natural 45-degree oblique, so you're not having to guesstimate it quite as much. But that is something available to you should that facility have those sponges. So I definitely highly recommend using these if you have them. If not, we are going to put the hand in a natural 45-degree oblique, and there is a pretty easy way to do this, which let me show you guys real quick. Let me take the sharing off so you can see me. Everyone see my hands okay? You can see my screen? Okay, let's pretend this is the IR. But we're talking about doing oblique hands or fingers. The easiest way to put the hand in a 45-degree oblique so you don't guesstimate it quite as much, here's our hand in a nice PA. If I tell my patient to make the OK sign like this and rest the hand down, like so, and then I relax the pointer finger after I've done that, the hand is in a natural 45-degree oblique. You tell your patient to make the OK sign, you rest the hand on the cassette, like so, move your pointer finger up, and then your hand's in a natural 45-degree oblique. And that applies for the fingers as well. You just got to center the correct finger. That's the easiest way to put a hand or finger into a natural 45-degree oblique. Not in your book. That's just my personal method of how to do that. Easy. Very easy.
Mr. Donahue, I have a question. If you tell the patient to do the same position and they do it, but whenever you take the X-ray, they move, just go with that picture? Or do you want them to like do it? Like, what would you suggest?
So you're saying, let's say that you had the patient in position and they moved it last minute and like it was in, like had motion or it cut anatomy off. So what you're talking about?
Yeah, like the type of position the patient in the fan, but when I took the picture, he was like,
Well, really, it depends mostly on how the quality of that X-ray looks. So let's say it was a little off center because they moved, but the X-ray still demonstrates that anatomy very well. You wouldn't repeat it. You would repeat it if anatomy is cut off or if there actually is motion visualized on that radiograph. But if it's still within the light field and you can see it, even if it's a little off center, typically you would not repeat it. So we gotta use some critical thinking skills and look at your X-ray really close and see if it's worth repeating or not. But did I answer your question a little bit? Yeah.
yeah, I did. Thank you.
No problem. So use the OK method, guys. It works like a charm. I'm telling you, it's the easiest way to get those oblique hands or oblique fingers. All right, so evaluation criteria for an oblique finger. We do want the entire phalanx and the MCP joint specifically to be demonstrated. That is one of the reasons we do an oblique, by the way, of a finger, is to open up those joint spaces a little wider in case there is a problem going on with the joints. The radiologist can get a clearer view of those joint spaces. So that's the IP and the MCP joints specifically that we're going to open up with those obliques. Central ray is still at the PIP. Using those low exposure factors, culminating nice and tight to that finger we're visualizing. We're looking there for there to be no motion at all, just a slight motion to make that X-ray great. So we got to set fine detail on those X-rays. So there's our MCP joint all the way on the bottom of the film. That's what we got to include, MCP joint all the way to the tip of the finger on these oblique finger X-rays. So we're not as concerned as with the PA to have that entire metacarpal demonstrated. On the oblique, we're only interested in the MCP joint to the tip of that distal phalanx. Okay, so for lateral fingers, once again, same thing here, guys. When we talk about lateral finger, we're still referring to the digits 2 through 5, not the thumb, 2 through 5. The digit must be parallel to our IR. Our central ray will still be at the PIP on these lateral fingers. Now, there is a little bit of a change here. Depending on which digit we are X-raying, we will position the hand differently. Let me minimize this again, show you what I'm talking about. So we are going to put the finger that we're visualizing in the lateral position. If I am X-raying digits 2 and 3, I'm going to put that digit closest to the IR by turning my hand like so. Middle finger, like you're flipping the bird, you're also going to put it just like this. Now, if I'm X-raying digits 4 and 5, I'm going to turn my hand the other way and put my 4th digit right here and my pinky finger right here. So if I'm doing digits 2 and 3, I'm basically putting the thumb side down of my hand, depending on which one I'm looking at. If I'm doing digits 4 and 5, I'm putting the pinky side down to put it as close to that IR as possible. Now you will notice if you're doing the middle finger or the 4th finger, there is going to be a little OID. We actually cannot help that. That's considered acceptable. But the pinky and the 2nd digit, 2 and 5, we should not have OID because we actually touch it to that film and make it nice and flat. So 3 and 4, OID is acceptable. 2 and 5, we're going to reduce that OID as much as possible and put it nice and flat on our film. Just make sure you turn your hand correctly to get that as close to that film as possible, depending on which one you're looking at. That's going to put it in a true lateral position. That's what we see right here on the PowerPoint. There's that 2nd digit. thumb side down, nice and flat, touching the IR. Third digit, there is going to be a little OID. The thumb side down once again, put it as close to the IR as possible. Fourth digit, we're putting the pinky side down, a little bit of OID, which is acceptable. And then the pinky or the fifth digit, we can actually put that flat on the IR, and we're going to put it nice and firmly centered on that IR, centered at the PIP, collimating down to that specific finger to raise up that detail. You will see them utilizing these sponges as well on these laterals. Once again, if those are available to you, that helps the patient isolate the finger. If you've ever done that to your own finger, sometimes it's going to be hard to turn the hand like that and hold that one finger out without it curling up. You can utilize those sponges to help isolate those fingers. You can also use tape to try to tape those fingers in place, especially if it's broken and they can't move it. There are different options you can actually utilize throughout radiology to help isolate those fingers and keep them very still. So it can be a challenge to hold the finger like that in a lateral position, especially if it's in pain or broke. Sometimes they're going to need assistance. Sometimes someone will have to actually stand out there and help them. Stand out there and help hold that finger still. Make sure it's not moving around. And your patients that are arthritic, like arthritis, sometimes they can't even move their fingers at all. So you really got to get in there and help them isolate those fingers and hold them really still for them. A lot of the elderly patients have very shaky hands. We want to reduce that motion as much as possible. Whatever we got to do, whether we're standing there holding that hand in place, taping it down, using sponges, that's where the critical thinking skills come in once again. How can I acquire the best x-ray, isolate that finger, and keep it as still as possible? Jonathan, did you have a question?
Yeah, I just wanted to clarify one thing. You said the second and third digit, you're going to put the thumb side down?
Yes.
And then fourth and fifth, it'll be pinky side down?
Correct.
Okay. Y'all can correct me if I'm wrong. Did Mr. Fong tell us just for the second digit? I thought I remember that, but I'm not sure.
Yeah, I remember that too.
He did say.
Also, this image here in the PowerPoint, it looks like the thumb side is up, right? For the third digit? What do y'all think?
Yeah, I think I see that too. Yeah.
That's the right hand?
No, you're right. You're right. You know what? I'll clarify that, guys. I'll clarify that and let you know. That's the way I was taught. I'll go back to Bontrager and make sure, guys. Sometimes I go back to Merrill's. I learned out the Merrill's book. Let me clarify that, and I'll let you know. Don't let me forget that.
Okay, thanks.
Thanks for bringing that up. If there's ever any inconsistencies there, let me know. I'll make sure it's clarified. Okay, so evaluation criteria, guys. For the lateral finger, 2 through 5, we want that entire phalanx and MCP joint demonstrated, same as the oblique. We're not interested in the metacarpals. We just need that MCP joint to the end of that distal phalanx demonstrated on that x-ray. Our central ray must be at the PIP, and we want that true lateral position. We acquire that true lateral by putting that finger in the correct position, getting as close to that IR as possible, making sure it's isolated, not bending, not moving. Can be a challenge depending on the type of patient you have, but be available to assist them if they need that assistance to keep their finger still. Digit must be parallel to the IR, and of course centered to the IR, like we just talked about. Make it as central to that IR as possible. That's going to raise the quality of your x-rays. Small exposure factors, very small collimation field, collimate down to that one finger, and no motion. Now, that method I talked about earlier about including 2 fingers, if you were ever do that method in real life, you would only do that on the PA and the oblique. You would never do that for a lateral. For lateral fingers, you're always going to isolate the one finger that you're interested in. Unless you're doing a hand with a fan lateral, it's a different thing. For fingers only, you're going to isolate the one finger. And that's what we see on this x-ray right here. It's a little bit superimposed, but our MCP is all the way down here on the bottom of the film. We do not include that joint all the way up to the tip, very tip of that distal phalanx, or the head of that phalanx. Now our joints nicely demonstrated, PIP and DIP. Proximal phalanx, middle phalanx, distal phalanx. And one way you can tell it's in a nice true lateral, look at the shape of the head of this proximal phalanx. It's superimposed upon itself. If it was oblique, it almost looked like it had 2 little heads going off here. But in a nice true lateral, it's going to be superimposed upon itself, have a nice pretty view. The joint's going to look moon-shaped, like an upside-down moon, and semi-open as well. So let's talk about the thumb. Like I said, the thumb does have its own category. We isolate the thumb and consider it its own separate exam. So for an AP thumb, a CR will be perpendicular to the first MCP joint. First MCP joint. MCP joint is your knuckle. So if you find the knuckle on your thumb, that's where you want your central ray to be. When we talk about the routine x-rays for a thumb, that's going to include the AP, the oblique, and the lateral. Now, it's very important when we do a thumb that we try to primarily only do AP x-rays. And the reason for that is if I ever opted for doing a PA thumb, you cannot acquire a PA thumb without OID. It's obviously going to magnify the image, and we don't want that. AP is the only way we can get that thumb completely nice and flat on that cassette without OID. You're actually going to turn the hand. You guys see my screen? That's really hard to demonstrate this on the camera. If you remember from lab, you're going to turn that hand upside down and pull the other fingers out of the way, pull them back, because patients will not hold their hand like you see in the picture here. You actually got to pull those fingers back yourself, isolate that thumb, put it in a nice true AP. Nice true AP. Centering on that MCP joint. Now there's the exception right there, that PA thumb. Once again, you do not want to do this unless you have no other choice. Because no matter how you position that hand, if you do a PA thumb, you're going to create a lot of OID. It's going to magnify that thumb. The quality is going to go way down. This would be a last resort if the patient just could not physically get in that AP position or refuse to. And that was your only option to acquire an x-ray. If you do a PA thumb, the CR is still to that first MCP joint right on the knuckle of that thumb. That cellar joint. Cellar joint.
The SID is going to be the same, or?
The SID will be the same. Still 40 inches. Yeah, everything we're doing this whole semester of science will be 40 inches, no matter what. And of course, everything we're talking about this chapter is tabletop, guys. I don't think I mentioned that before. Everything's tabletop on top of a cassette. You're not going to do any of these in a table bucket. You're not going to do any of these on a wall bucket. It's all tabletop on the actual cassettes. Okay, so the evaluation criteria for that PA or AP thumb. We want that entire thumb to be demonstrated. We must include the first CMC joint. It's a little different from the other fingers we talked about. That first CMC joint must be included on a PA or AP thumb. Your CR is going to be at that first MCP joint. You have zero rotation of that thumb, low exposure factors, and very tight collimation. Very small body part, therefore we still need that tight collimation. And no motion, of course. No motion at all. Now you will see some text. This is the way I learned it, by the way. Like I said, I learned out of a different book from you guys. They taught us when we did these x-rays to actually include all the way down to the bottom of the wrist. We actually included the styloid process of the radius on our thumb x-rays. And the reason for that is a lot of fractures would occur on the thumb. Would actually go all the way down and actually fracture parts of the radius as well. So the way I learned it was including all the way down to that radius. But for you guys, you only got to include it down to that first CMC joint. That's all that's required for you guys. It's a little bit easier overall. You can see our trapezium. Do make sure you make note that trapezium is located just distal to that first metacarpal. It's that first carpal bone we should see. There's our first CMC joint. Of course, there's our MCP joint. That's where our central ray is going to go. And our proximal and distal phalanx. If you do remember on the thumb anatomy, guys, thumb does only includes a distal and proximal phalanx. It does not have a middle phalanx. That's a unique feature of the thumb. Also, the thumb only includes an IP joint. It does not have a DIP or a PIP. It only has an IP, interphalangeal joint. It's a very important thing to remember on that thumb. It's an easy thing to get tripped up on. I would write that down, put a star on it. The thumb only includes an IP joint. It only includes a distal and proximal phalanx in comparison to the other digits in the hand.
Can you repeat that?
Mm-hmm. So the thumb, or the first digit, only includes an IP joint, and it only includes a distal and proximal phalanx. That's in comparison to digits 2 through 5, because each of those include a DIP, a PIP, and a middle phalanx. So one more time, thumb only has a distal and proximal phalanx, and it only has an IP or interphalangeal joint.
Thank you.
Okay, so for an oblique thumb, very, very easy exam. I'll tell you why. To do a PA oblique thumb, all you have to do is put the patient's hand flat on the cassette. When you put someone's hand flat on the cassette, guess what the thumb does? It naturally goes into a 45-degree oblique. So you don't have to make any adjustments whatsoever. The only thing you have to do is make sure you're centered to the MCP joint and central to your film. So put the hand flat on the cassette, move the thumb over so it's central to your cassette, and just make sure your central ray is right at that MCP joint. All you got to do, very, very simple. The hand will naturally put the thumb in a 45-degree oblique, which we can see right here on this x-ray. All right, we of course do want to have the entire thumb demonstrated. That's going to include the tip of that distal phalanx all the way down to that first CMC joint, same as the PA or the AP. The joints will need to be partially open. That's why we do the oblique. Anytime we do the oblique on the hands or the fingers, we're doing those obliques to open up those joints. So we're opening up the MCP joint, we're opening up the IP joint, and we're also opening up CMC joints. There's three major joints in the thumb area. CMC, MCP, IP. It's the primary reason we do those oblique x-rays. The central ray is still at that MCP like we just mentioned. Small exposure factors, very tight collimation, and we of course want to isolate that thumb and make sure it's not moving around. Zero motion if possible. And do make sure you make note, one of those key features of thumb will also include a lot of times that sesamoid bone. There's that nice little sesamoid bone. And more often than not, it's located right next to that MCP joint, on the inside of that first metacarpal, the medial side of it.
Mr. Donahue, PIP and IP is the same?
No, they're not. So PIP and DIP are only found on digits 2 through 5. The IP is only found on the thumb.
All right. Thank you.
The thumb is unique. It has its own set of parts and joints.
Thank you.
Welcome. All right, so let's go to our lateral thumb. Lateral thumb, the CR is still at that first MCP joint. Now, to put the thumb in a lateral, I always put my patient's hand flat on the cassette first, and then I rotate their hand medially just a little bit. When you rotate the hand medially, the thumb will naturally go into a lateral position. It's natural. And I'll demonstrate these a little more, guys, next week. I'll try to get a different camera set up so I can demonstrate these to you guys live, show what I'm talking about. But as we rotate that hand medially, the thumb will naturally go into a lateral. And then all the criteria is going to be very similar to that oblique we just listed. There we go. That's what I was looking for. We do want the entire thumb demonstrated. Once again, the tip of that distal phalanx all the way down to that first CMC joint is our primary evaluation criteria for a lateral thumb. Our central ray is going to be at the MCP joint. There needs to be no rotation because we must have that thumb in what we call a true lateral. We do that by having the proper positioning of medially rotating that hand. Low exposure factors, tight collimation, and zero motion, same as what we just talked about. We are including that entire thumb. Just watch your marker placement on those finger x-ray, guys. Probably the biggest mistake I see is that people forget to put their markers on these. It's very easy to cut them off, especially when you're utilizing very tight collimation. It'd be a very easy mistake to cut those markers off. And we'll see the trapezium listed on a lot of these thumb x-rays. Do keep in mind what's nice to have that on the x-ray. The only real requirement as far as criteria goes is that we only need to see that first CMC joint. So if you want to be really fancy, you could shave off a little bit more of that on the x-ray, but it's not necessary. As long as you have that CMC down there, you're in good shape. Okay, so this is where we're going to stop today, guys. I'm almost out of time. On Monday, we will pick up with the hand and the wrist, as well as the forearm and the elbow. We'll start wrapping this chapter up, and then we'll do a good, big review of everything for your tests. We'll have some more practice images for you guys as well for the anatomy next week. Are there any questions about what we talked about today? I will clarify that position on the lateral fingers and let you guys know. Make sure we have that information the same and accurate. And who's going to lab? Who's about to go to lab? I will see you guys up there in a little bit. I actually got to go up there myself to pack up my office because we're doing a big move. I got to get all my stuff packed up, so I'll see you guys up there. Other than that, everyone else have a very nice weekend. I will send you the rest of the PowerPoints. Let me know if you have any more questions, and I will see you all on Monday. Bye-bye.